Good evening, good afternoon, good morning, everyone. Thanks for joining for our last virtual 5x5 symposium. Will all radiotherapy be delivered in a maximum of 5 radiotherapy fractions? Let me share my screen. And so this is, as mentioned, the last session of our symposium. We have started on the 20th of May, started with rectal cancer. We have discussed breast cancer, prostate cancer, pancreatic cancer, and today I'm very happy that we have another exciting topic, non-small cell lung cancer. But important things first, I know that some people might be interested in football. So here's the really important stuff. The match Ukraine versus North Macedonia has just been finished. It's 2-1. And I can promise you we will finish sufficiently in time that you make it to the next exciting match, Denmark versus Belgium. But now let's get into our topic of lung cancer. And I want to make the introduction very quick and give you kind of an historical perspective of the achievements and maybe also the challenges we have been facing in the field of stereotactic radiation or radiation in general in non-small cell lung cancer in early stage disease. And I picked some key publications and findings. The first kind of innovation was described in 1994. So more than 25 years ago, Lux and Blomgren described the basic principle of stereotactic radiation using the body frame technology. In only 4 years later, it has been applied to early stage non-small cell lung cancer. This was from our Japanese colleagues, Uematsu et al., primary and secondary non-small cell lung cancer. And already at that time, they reported that only 2 out of about 40 patients developed local disease recurrence with technology, which we would assume as insufficient from today's perspective, and also radiation doses, which we might assume from today's perspective as being too low. In 2004, it was Onishi and this group publishing this magic 100 gray BED, which we need to cross as radiation oncologists to achieve a durable local tumor control. And going even further, Optimum and McGarry published their RTOG phase 1 dose escalation trial, showing that we can go even higher with modern technology, going to 3 fractions of 20 gray. Maybe we were also flying too high. This was the first high-ranking publication about stereotactic radiation. The first time stereotactic body radiotherapy made it into a big oncology journal, the JCO, and it was describing excessive toxicity when SBRT was applied to medically inoperable early stage non-small cell lung cancer. Of course, we know this was in centrally located locations, but that's what was sticking in the mind of many people, that this high dose radiation might also have its dangerous aspects. And despite we have in later phases shown, and also our keynote speaker was involved here, that in a randomized comparison, despite not fully recruited, we achieve similar, maybe even better results, but at least similar results to surgery. And this seems to be also true in the long term. Now in the Astra, this concern about using very high dose per fraction, ablative doses, has been something we are worrying, and our community has been worrying. So the question is truly, how high can we fly? So there needs to be an intermediate zone where we can obviously have an ablative treatment, but not flying too high, such that the heat of the sun makes us lose our wings and make us drown and go to the ground. So before we start the symposium, I would like to interact, to integrate you and ask you 3 questions. This question is always be the same. How would you as a clinician or a physicist, fractionate radiotherapy in the 3 patients shown below? Patient 1 is, they are all medically inoperable, stage 1 non-small cell lung cancer. You can see here the peripheral location, and you can see here the arrow. So that's what you want to treat. This is patient number 2. Tumor is larger, it's attached to the chest wall, and according to current definition, it would also be called a so-called centrally located non-small cell lung cancer, still at early stage without lymph node metastasis. Assume, please, that it's all biopsy confirmed. And the third case is a bit more tricky. you can see here some clips. So this has been stage 3 non-small cell lung cancer being operated 4 years ago. And that patient developed an isolated nodal recurrence. And that is something which we would call ultrasensual. So please now vote how you would treat these 3 patients, either in a single fraction radiosurgery, 3 to 5 fraction SBRT, whether you would apply some risk-adapted fractionation, 6 to 12 fractions, maybe you would use 20 fractions, a soccer scheme, or use conventionally fractionated radiation. I will not address the issue of chemotherapy and how to integrate. That would be too complex for that starting questions, but please vote. So how do the results look like? The patient number 1, a peripheral early stage non-small cell lung cancer, the majority would use an SBRT approach, and 74% would use a 3 to 5 fraction regimen. Single fraction would still be favored by 14, 6 to 12 fractions by 10%, and the soccer and the conventional fractionation was only 1 person voting. The second case, which we described as essentially attached to chest wall and still being larger, single fraction was now being chosen by 0, 3 to 5 fractions by 20%, and the majority would opt still for an SBRT regimen in 6 to 12 fractions, soccer and conventional fractionation catching up with 14%. And going to the last case, this late recurrence, regional recurrence of an locally advanced non-small cell lung cancer, no single fraction and 5 fraction SBRT, still 22% opting for 6 to 12 fraction SBRT. Soccer, so 20 fractions over 4 weeks, would be favored by 1/3, and the majority, almost 50%, voted for the conventional fractionation. That as a point of where we could start the discussion afterwards. But now let's move forward. And before I introduce our keynote speaker here, some housekeeping remarks. Everyone who has joined our symposium knows it already, but still the summary. Please make this an interactive experience and use the questioning and answering functionality of Zoom to interact. All presentations will be recorded and all answers will be questions will be answered in a written format. And here is our QR code to our webpage of the symposium, where you will find the presentation. CME credits will be sent via email, and please also evaluate the symposium afterwards. I would like to thank Decro and Estro for endorsing this event, and also thank our industry partners, Varian and Viewray, for their kind support of this symposium. With that, it's a true pleasure to introduce our keynote speaker of today, Professor Suresh Senan from the University Medical Center in Amsterdam. Everyone who's working in the field of lung cancer knows you very well, and I would give an introduction which is maybe a bit untypical. I would start saying that Suresh does everything which all other people also do in the field of lung cancer research. But there's one minor difference. Suresh started that field of research. He was being first. He's one of the most innovative drivers of our field in radiation oncology, early stage lung cancer, locally advanced lung cancer, integrating technology, and also integrating modern systemic therapy. So it's a true pleasure having you here in our symposium, Suresh, and I thank you very much. I'm looking forward to your presentation. So please, Suresh, the floor is yours.
Thank you very much for the kind invitation and introduction, Matthias, to talk about 5-fraction radiotherapy in a curative setting for lung cancer. My disclosures are summarized. Perhaps the first 2 are most relevant for this talk. I've been asked to touch on the evidence for fractionated SABR in early stage lung cancer, and to also go on to explain the data on single fraction SABR for early stage lung cancer, which is the other extreme of what we've normally been doing. And also to review some of the literature on 5 or fewer fractions being used in oligometastatic disease with a radical intent. So this is what many or most of us do for our early stage patients. You have a LINAC with a cone beam. You look at the guidelines and you do volumetric setup. In this case, the patient got 5 fractions. You follow the patient up. You know there's a scar that's going to come up, and it's metabolically cold at 36 months. And this is the sort of work practice which people all over the world are doing, supported by findings of the Chisel trial published 2 years ago, showing that there's a improved local control and also survival when you treat these peripheral tumors with SABR. Because it's become widely used, we can now study it in populations. And this is a paper which recently appeared on 100,000 patients with clinical stage 1 lung cancer with 2-year overall survivals from England, Norway, and Netherlands. I thought in the spirit of the Euro competition, I would use this figure. But the point I want to show you is that when you look at SABR or SBRT here, the 70+ age group, at least in Norway and Netherlands, where access has not been a problem, you get a 2-year survival of between 70 to 79%. And if you look at surgery in the 70+ group, it's about 90 to 83%. You can see that Norway is actually winning this. They do better surgery. There are better outcomes in both SABR and surgery. But in this paper, we didn't actually compare these countries, but it gives you an idea when it's established. There are hundreds of thousands of patients being treated, and this is survival for patients from 2015 to 16, and this 2-year survival. And it's important because if you look at operable patients, Matthias referred to this, after the SABR STARS-Roselle trial in operable patients, Dr. Cheng and the MD Anderson continued to expand accrual into the STARS trial. So it was 80 patients who were judged by a tumor board to have operable lung cancer. 3 centimeters or less, they follow them up for 5 years. They use a 3 or a 4 fraction scheme, and they have a 5-year overall survival of 87%. So the previous slide, I showed you 2-year survival. This is 5 years. So it's quite impressive with hardly any toxicity. Grade 3 was the maximum, 1.3%. Local recurrence, these are for 3 centimeters and smaller, 6% only. And the local recurrence rates actually compare with the cumulative incidence of second primary tumors. So we're just as likely to treat a second tumor with SABR in these patients as we are to have a local recurrence. Regional recurrences in 12.5%, but many of these patients could be salvaged, and distant recurrences of 8 and 8.8%. So we have data in a surgical cohort who were treated with SABR and followed up for a long time. I think these are new benchmarking data. I know we don't like propensity score match analysis. That's a virtual trial by trying to get 2 groups of patients, but Dr. Cheng's trial actually pre-specified this in their protocol. They did a propensity score analysis, match for age, gender, size, and histology. And they compared VATS lobectomy with mediastinal lymph node dissection in a contemporaneous cohort of patients treated at the MD Anderson. And what this showed is that there were no significant differences in overall and cause-specific survival at 5 years. SABR was 87%, surgery 84%. And the conclusion worth remembering is that long-term overall survival and progression-free survival is not inferior to VATS lobectomy when you use 3 or 4 fraction SABR. So this is a sort of term we coined in 2008, and I confess and apologize for it, risk-adapted SABR scheme. So if it was a small lesion in the middle of the lung, you treated it with 3 fractions. If it was broad contact with the chest wall, in 5 fractions, and if it was central, in 8 fractions. So for years, we and others perpetuated the concept you were a safer doctor, a better doctor, delivering more careful treatment if you use more fractions. So now I'll explain why we're trying to teach people that that's not true. When you do a trial, you have to reassess your beliefs. And the RTOG did this trial comparing a single fraction of 34 gray to 4 fractions of 12 gray in patients with pathology-proven tumors measuring 5 centimeters or less. The primary endpoint was if each arm would be considered promising, if the 1-year incidence of grade 3 or higher adverse events was less than 5%. It couldn't include central tumors and tumors touching the airways or those more than 5. And you had to have a 1-year primary local tumor control of more than 90%. It was not a particularly big trial, but you will note that tumors up to 4.3 and 4.9 were included. Most were T1, and these were patients with impaired diffusion capacity, less than 50%. And what they showed with very long follow-up is that there was no excess in late toxicity, similar primary tumor control at 5 years, and similar efficacy. Some clinicians, some radiation oncologists were concerned. They said, yes, but the survival, the late survival seems worse on long-term follow-up, but we shouldn't be perform the same mistake that surgeons do when they compare late survival after SABR with surgery, because what drives survival in this patient population is comorbidity, and the studies are not matched for comorbidity. A second North American trial was by Dr. Anurag Singh, who compared 1 fraction of 30 gray with 3 fractions of 20 gray. It was a 4-institution trial. Phase 2 randomized again, and the endpoint was grade 3 or higher toxicity. And the 2-year local control was about 95% or higher. That was also reassuring. So there's high-level evidence in randomized fashion supporting use of single fraction. And for those who are concerned about chest wall, this is a retrospective analysis from the Cleveland Clinic, where they had nearly 146 patients, lesions, close to the chest wall, but where no chest wall constraints were applied. They just planned them and treated them. And the key figure is that chest wall toxicity was just in 15%. And most of them were grade 2, very few grade 1.4% grade 3. And these columns show you the distance. If it's about 1 centimeter of the chest wall is 8.2%, but if it adjacent or butts it is 30% chest wall toxicity. We're talking about a curative treatment, and we're talking about low-grade toxicity. Yet, this is the commonest reason why many people are nervous about treating tumors close to the chest wall with single fraction. It may not be justified, and we are reassessing our practice because this is not a grade 2 toxicity is not a reason to not to use single fraction if it's within 1 centimeter of the chest wall. I'm sorry, I just wanted to show one more point. Even patients who had low rib doses could develop fractures or toxicity, as those with high doses, a volume getting 1 cc of the rib. So our new concept of risk adapted includes single dose SABR. So if you have to forget one word, it's risk adapted, except for central perhaps. I should be treating this with 1 fraction. Should I also be treating this with 1 fraction or 3 fractions? Well, let's look at the evidence. For central tumors, the ESTRO guidelines said that SABR directed at central tumors should be delivered in 4 to 5 fractions, but you should adhere to volumetric and maximum dose constraints to improve safety profile. And because we in ESTRO could give feedback, they also added the sentence, central tumors for which SABR is deemed too high risk, hypofractionated radiation therapy using 6 to 15 fractions can be considered. I will come to what they mean by recommendation strength, conditional. There was high consensus in the panel. So they wanted you to believe that you should be treating in 4 to 5 fractions central tumors. Well, what conditional means is that They make it when the balance between risks and benefit was more even or uncertain. In these cases, the task force of ASTRO believed that most informed people would choose the recommended course of action, but substantial number would not. I would argue in Europe, most people would not use 3 to 4 fractions. So there's room to express your views. It is not hard advice. And it's also about risk tolerance and perception. So this is work I was privileged to collaborate with on NCDB analysis of nearly about 85,000 patients, of which 8,000 had SBRT and 76,000 SABRE. This is the 90-day mortality. You know, when you hit chest wall toxicity, it's months to years, but this is 90 days. If you were a patient with a central tumor which required a pneumonectomy, you could have a mortality of up to 20% in the US National Cancer Database. And if you're lucky, it's only about 5 to 10%. If you had a lobectomy, it could be as high as 7%. So these are immediate and real risk. And this is the reason why many of us actually continue to use some form of SABRE for central tumors. And what did the data show us? This is from 2 pooled Dutch analyses. And we looked at bronchial toxicity for central tumors, nearly 200 of these. And we analyzed toxicity according to the green squares, which is stenosis, radiological toxicity, occlusion, which was blue, and occlusion with atelectasis, which was red. And we used radiographic scoring in order to get more endpoints. Nearly 30% had toxicity, but clinical was lower. And most of the toxicities in this analysis manifested in 12 months. What it told us was grade 3 or higher toxicity clinically was higher if the PTV overlapped the trachea of the main bronchus, if the total V130 gray EQD was 130 or higher, or if you had COPD. So this gave us some idea what not to do, even when you use mainly 5 fractions or more. But there are new insights from trials, and data from trials are always preferred to institutional reporting. So the first one I want to touch on is the RTOG 0813 trial for tumors touching the zone 2 centimeters around the proximal bronchial tree or immediately adjacent to bronchial or pericardial pleura. Finally, only 17% were ultracentral. That's an important point. And the primary objective was dose grade 3 or higher, dose limiting toxicity within 12 months, not later, within 12 months. Secondary objectives were much later toxicity, and they also looked at progression-free and overall survivals. They started off with 5 fractions of 10 gray and then escalated upwards. In 5 fractions of 10 and 10.5 gray, they showed no dose-limiting toxicity as determined by independent review, that is 12 months data. But once you went to 11, 11.5, and 12, things got interesting. 4 patients in the 11.5 and the 12 gray fraction each had a grade 3 toxicity during the first year, but we followed them up later. There were grade 5 toxicities, 3 in the 11.5 and 1 in the 12 gray per fraction scheme. Again, to remind you that most of the patients in this study did not have what we call ultracentral tumors, where the planning target volume overlaps the central airways. There are different variations. Some people use the gross tumor volume overlapping it, but generally, this trial does not inform us about the safety and constraints of treating ultracentral tumors. The HILAS trial, again, a trial which was given in 8 fractions, has caused a bit of an earthquake in the radiotherapy world, stereotactic world. This is a prospective multi-center phase 2 trial for tumors located 1 centimeter or closer. So if it was less than 1 centimeter from the main bronchus or trachea, it's group A, one group, and the other group are all other patients. Endpoint was local control, secondary endpoint was toxicity. And I remind you that prescribed it to the 65 to 70% isodose line. So when you say you're giving 7 gray per fraction, it could be far higher. because they didn't, I'm not going to go into the details, they didn't contour some of the smaller airways or blood vessels, this very high dose could actually be landing in the middle of those structures, 8 fractions, about 10, 11 gray. But they did use cone beam CT setup, and they had a median follow-up of 24 months. And the shocking thing was the bleeding, risk of fatal bleeding or grade 5 bleeding, which in this column, part of the panel shows if it was very close, 0 to 5 millimeter, the risk was the highest. It was coming down to what, 30 plus, 35%. But if it's more than 10 millimeters, the risk was low. It tells us that we're not safe even using 8 fractions when we treat central tumors, because we're not quite sure what the constraints are. So we paid the price for having too hot a scheme, but I do not think that central Staber is going to fall into disgrace. We need to be hot because we have lower local control rates. Dr. Cheng's trial showed local failure rates about 6%, but we have in the systemic review about 10% failure at 2 years for central lesions. In the Hylas trial, about nearly close to 20%. And this is the Mayo Clinic data showing about 20% failure, about 30% failure at 5 years. So we're not doing as well as we like if we use less hot regime. So the trick seems to be to find the sweet spot of putting the hot doses where it's safe. And that's where we need to know, where is it safe to put the hot spots and where is it advisable not to do it. To round off, I just want to touch on some of the lessons from the metastatic trials, which have been presented recently. So Shankar Shiva presented the data on the Saffron 2 trial, 1 to 3 metastases randomized to either one arm, single fraction of 28 gray, BD above 100, or 4 fractions of 12 gray to 48 gray. And the endpoint for this phase 2 trial was a maximum acceptable rate of grade 3 or higher toxicity events being less than 5%. He presented the data last year showing that the primary endpoint was met in both the 1 times 28 gray and the 4 times 12 gray. And he had some difficult tumors as well, colorectal tumors, which we know has a tendency to recur more often, and only 11% were lung. And the oncological outcomes at the time of analysis were also good. But at 12 months, it's about 93 and 95%. And the only fatal toxicity was in the multi-fraction scheme. So in metastatic disease, single fraction seems to be acceptable as well as a 4 fractions. This is a single arm trial. Dr. Greco and his collaborators from Memorial Sloan Kettering, they use patients with oligometastatic disease, and they use something called sequential emergence of oligometastasis. So you repeat the SABR. And the primary endpoint is the feasibility and efficacy of 24 gray single dose in ablating these lesions whenever they were detected. If you couldn't meet the constraints for 24 gray, they could allow you to get 3 times 9 gray. What you see here is that those who got 24 gray had a good local recurrence-free survival, 92% with long follow-up. Those who got 3 fractions because they did not fulfill this criteria did poorer. But it also is a message on motion management. After 24 gray, the 3-year local control for non-small cell and colorectal in the adrenal and liver was only about 50%. Versus 88% if you had these 2 tumor types having metastases in other organs. These 2 sites, liver and adrenal, are devilishly difficult to treat if you do not, with a single fraction, if you do not have impeccable motion management. So the standard motion management is unforgiving when you give single fraction. The last trial is the BR001 phase 1 trial, where they included 35 patients with oligometastatic breast, prostate, and non-small cell. To be eligible, they had to have 3 to 4 metastases or 2 metastases in close proximity, less than 5 centimeters. And the endpoint was not 1 year, it was 180 days, all grade 3 and 5 toxicity. So if you just follow things on Twitter, you say, no protocol defined dose limiting toxicities observed, and you're happy. But if you read the paper, you look into the details, you find that for the central lung mediastinal cervical nodes, they use 5 fractions of 10 gray. About more than half of the patients are alive at 2 years. You do have late toxicities, not the 180-day, but as time goes on, the percentage of grade 4 toxicities, grade 3 to 4, rises. And for the 5 fractions to the right, to the hilar region, you get bronchial stenosis and bronchial fistulae. So the 2-year cumulative incidence of late toxicity, if you use 5 fractions, not in the middle of the lung, but in the hilars, is about 20%. So to finish off, I'm just going to show an example of a patient treated at our center with a biopsy-proven hilar nodal metastasis of renal cell cancer. He was 50 years old. He had progressed after systemic therapy on this site. He was treated in 12 fractions of 5 gray, which we thought was a reasonably safe dose. The colleague who treated him. After 2 years, what you see is a fairly severe narrowing of his airways. He had some radiation pneumonitis, but this was persistent. And this is something we saw 2 or 3 weeks ago when he was presented with the tumor board again. You can see that the airways are getting slower and narrower. Patient didn't have much problem, but the urology team kept repeating PET scans and saw some slight uptake in this region. So the greatest danger to this patient now is the risk of some ill-informed person trying to do a endobronchial biopsy and causing bronchial necrosis and fatal hemorrhage. So these are late changes we're going to see in survivors, and you wonder whether you could have done it better than when we did it in 12 fractions of 5 gray. We have local control, we believe, but we have a sort of a time bomb here. We don't know what's going to happen in the next few years. To limit both hotspots and high-dose organ at risk volumes, we use MR-guided on-table adaptive treatment. And I hope you can see the movie here playing, patient performing repeated breath holds. They get to see this gating window target, which they have to manipulate the tumor, which is being tracked to come into this. So this visual feedback system, which many users of this type of MR-Linac have, project the target volume and safety margins on a wall-mounted monitor. We use a breath hold GTV to PTV margin of 5 millimeters. The gating margin is 3 millimeters. We do daily on-table plan adaptation to prevent hotspots. And this is feasible. And this is an example of a patient. Of course, I'll only show you an example where we did well. This was close to the airways. We would have probably treated with 8 or 12 fractions many years ago, but this is after 3 years. I see some airways. I hope they won't become even more narrowed when I look at it in 5 years. But we're deliberately trying to spare these airways, and by giving breath hold delivery, we're getting more dose certainty, so that in a couple of years, we will be able to say more about what is the true tolerance dose of these structures. The intermediate analysis presented by Dr. Finazi from Basel when he was with us, those are 54 tumors treated from 2016 to 18. We saw quite few grade limited toxicities, mainly grade 3, but you can see some of these tumors we treated were pretty centrally located to the pericardium and the airways. So I'd like to conclude by stating that we have taken a cautious route, but not a correct route, by calling everything with more fractions as being safe and risk adapted. A patient who has to come to a hospital for 8 times when he could have done it in 1 time is being exposed to all the risks in going to a public place where you do not want to, and being exposed to other risks. So single fraction is established. If you follow the guidelines of the trials, data from the trial inclusion, you could treat a lot of patients with single fraction. You could treat a lot of patients with 3 fractions, as Dr. Cheng has done in his extended STARS trial with 96%, 94% local control and very few toxicities. So if you have to, 5 should be the extreme. You are correct in assuming that we do not know what the most reliable organ at risk constraints are for central tumors. The longer the patient is expected to live, the more risk can manifest. For limited metastatic disease, we are using lower doses now, 24 gray, because it's a question of competing events. Many of the patients will get metastases elsewhere. The general survival is poorer, and it is not a disaster if a patient has an isolated metastatic recurrence. He can be operated upon, he can be re-irradiated. So when you give lower doses, there's more room to give fewer fractions. And that's what many of the trials do, because the patients are limited. They have a limited window where they're available for radiation. And we hope there'll be more data coming from people doing MR-guided radiotherapy and other prospective trials to show that increased safety of SABR delivery will probably be possible by using smaller uncertainty margins. Somebody pointed out to me, we shouldn't call it safety margins, but it's uncertainty margins. The more certainty you have with real-time on-table visualization and adaptation, the smaller the uncertainty margins can be. And with that, I'd like to thank you for your attention.
Thank you very much, Suresh, for this excellent overview. We have few questions, but maybe I would like to start with one in terms of how would you approach an operable patient? We've seen now tremendously good results from the expanded STARS trial, where we have long-term follow-up, excellent results in safety, efficacy. Would you also propose a single fraction approach in this young, fitter, and operable patient, or is that something which you would propose as being evidence-based currently for the typical inoperable patients, or maybe the metastatic patient?
Oh, I'm very happy to, on the basis of the evidence, I've been a bit reluctant. I was a late starter with single fraction. I'm very happy to do it for the operable patients. And I just should add that we do as many of those on the true beams as we do on the MR-Linac. MR-Linac's only reserved for those tumors which are big enough and they move a lot. So I do not wish for anyone to have the idea that you need the MR-Linac to do single fractions. A lot of it can be done, and I see no distinction between operable and inoperable patients for that.
Okay, I'm looking into the chat, so please use the chat functionality or the question answering functionality. How do you approach the setup? We have a question here. Do we need a cone beam CT scan after the treatment is finished just for verification purposes? Or can we omit that step?
Yeah, so for fractionated SABR, we do often use it for the first fraction. Not routinely, but if I wanted to use a smaller margin, it's a margin issue. We use the ITV on the normal CT Linacs. And sometimes when it's close to a chest wall or other structure, we use a smaller margins, and then we do a cone beam between arcs and a cone beam after delivery on the first fraction to see whether it's justified. For the single fractions, we use up to 3 cone beams and 6 arcs. We do a lot of cone beams repeatedly to make sure that the tumor has not shifted. So we use FFF with 2400 monitor units on the CT Linacs, and we still do extra cone beams. So we are very conscious that you could get it wrong if you don't do it perfectly.
So Suresh, allow me, that sounds like you're kind of putting 3 fractions just behind each other. So the total delivery time might be very similar compared to a 3 fraction approach, just to kind of make sure that the single fraction doesn't introduce a systematic error. Is that the rationale?
So I think if you look at the total time on the Linac, it'd probably be two stereo setups. Mm-hmm. For the patient, it's much less time coming to the hospital then if you had to come 3 times and wait 3 times in the waiting room, sitting next to people who may not wear masks and take public transport to come here. So the benefit is greater for the patient, I think, than perhaps for the department. You're right.
Okay, so we still hope that everyone wears masks, in particular in our waiting rooms. There's another question. Would you expect lower tumor control rate in ultracentral lung tumors when treated with 10 fractions of 5 gray with a dose prescription to 80%? Is better local tumor control sacrificed in order to avoid toxicity?
I think so. I would recommend that the questioner reads the paper by Dr. Breen in the Green Journal, where they published the Mayo Clinic experience. I think it's quite straight. It's nice because an American center has published the data where they actually recommended 2 things: use of the 8 times 7.5 gray scheme, and said do not underdose. And that's always been our previous thing, because they showed that, I think if the BED was below 83 or something like that, the recurrence rate increased. So the answer to the question is, if I could preferentially say spare the contralateral bronchial wall or something, that's fine. But I'm very reluctant to underdose the tumor at this point, certainly on a CT LINAC using an ITV approach, because to me, the greatest toxicity is tumor recurrence. It's just as bad as fatal hemorrhage. So I think the key message is use the best technique you have and be aware that if you underdose, you're going to have more toxicity. And the Breen paper in the Green Journal last month, I think, actually shows you what the trade-offs are.
Maybe one last question also from myself. You made a very strong point, a very correct one. I mean, the tumor recurrence is the worst outcome which a patient could develop. But what is, in your kind of perspective, the true organ at risk for central toxicity? Or is it different toxicities which we need to consider? Is it bronchial stenosis? That might be the bronchus wall. And where does the bleeding come from? Is it the vessels? Is it the bronchus? Could you elaborate on this? And or do we need to distinguish between the full kind of circular, or is it just the contralateral wall which we need to spare?
I think the short answer is I don't know. But if I look at the literature, and somebody pointed out that in our previous papers, when patients had endobronchial tumor, they had a higher risk. That's the first thing. And the second factor, which is quite strong, was from the Memorial Sloan Kettering. These patients get anti-angiogenic therapy. And I'm very wary about renal cancer and some other cancers where patients get anti-angiogenic agents in the time after it. And the third thing to avoid is curiosity. I showed you that patients, we have to repeatedly rescue these patients from people who want to do biopsies just because they're unsure. So my feeling is that if the tumor has actually grown into or through the bronchus wall, that's a very high risk factor. And when you biopsy it, you just biopsy a big fat juicy blood vessel, which may be just pulsing underneath the airway. So we always like to look at these images as a team and suggest, if it's that important, do a PET scan. Maybe it's a lesion somewhere else, will tell you it's progressed.
Okay, so I think we've made most of the questions. Suresh, thanks again for this excellent overview, for the excellent discussion. Please stay on board, and we will have a final discussion after the next talk. So the next talk will also address a topic which is very kind of up to date, where we see tremendous progress in very rapid time, combining SBLT with immunotherapy in non-small cell lung cancer. Let's start with an historical perspective, and maybe the most important, or the most cited, the most mentioned showcase report in radiation oncology, published in the New England Journal of Medicine a couple of years ago in 2012. So this was a melanoma patient. Many people of you know it. Patient developed a recurrence. He was started in ipilimumab and had a progressive disease. And well, this progressive disease was painful, so it was irradiated locally in a palliative fashion. There was some response here, which doesn't come as a surprise because, well, that's what we've irradiated. That's a local treatment. But interestingly enough, also the distant metastasis outside of the radiation fields at the hilum or here at the spleen were kind of regressive. And that was a longer period response. And that was assumed as a so-called abscopal effect, or an systemic effect of applying radiation in this patient having an immunogenic tumor and being exposed to an immune checkpoint inhibition. Maybe why many of us were surprised by this kind of synergistic effect is that we know about the immunogenic effects of radiation for a very long time, but from a different perspective. We know from 1902 that radiation is myeloablative, and that was used already in 1920s as a total body radiation. So the immunogenic effects of radiation are well known, but in the opposite direction as an immunosuppressive device, technique, treatment, or modality. And it is only recently since we understand somehow better why radiation might be a double-sided sword, that it can also have an immune enhancing, immune synergistic effect locally and also in a systemic level by immediate targeting the tumor cells, but also through the microenvironment. This summarizes what we can contribute as a radiation oncologist, because that's the discipline which we can deliver. That's what we can propose and offer to our medical oncology colleagues, that our discipline, our treatment might be a good partner for immunotherapy. And I would like to show this double-sided sword here again. Conventional radiation and stereotactic radiotherapy, and the evidence or some evidence based on preclinical studies below why this more focused, this ablative, this small volume SBRT approach might be a better partner theoretically on preclinical studies for immunotherapy compared to conventional radiation. We do have evidence on preclinical level that a smaller number of fractions is better than fractionated approach. We should not deliver total body radiation. If we limit our target volume to a small volume, where is it, the volume? Well, I forgot here, but volume is in effect. Single fraction dose, larger single fraction doses seem to be more immunogenic than smaller single fraction doses. The distribution here is the volume focused irradiation versus kind of a large distributed way of delivery. And also the combination, obviously radiation alone might or might not induce an abscopal effect in most patients, it doesn't. And there might be a stronger hope in the concurrent treatment with immuno checkpoint inhibitors. So that is something which we need to modulate, and that is something which we need to learn, how we can adapt the radiation to be a good partner with immunotherapy. In the next slides, I would like to give you a quick overview of what has currently been achieved in the field of combining radiation with immune checkpoint inhibition or with immunotherapy in general. And I would like to show you that we do have very promising or even practice-changing results at all stages in non-small cell lung cancer. Recently published by the New York group in early stage non-small cell lung cancer. It was a randomized design. Patients were treated with an SBRT as a neoadjuvant treatment or only durvalumab. So either the combination of 3 fractions of 8 gray plus durvalumab only 2 cycles, 3 weeks apart, or durvalumab only, and that was followed up by surgery. The primary endpoint was target regression after induction therapy. And you can see here the tumor regression rate. So the longer the bar goes down, the higher the tumor regression. And in a quite relevant number of our patients, when they were treated in the neoadjuvant or induction setting with durvalumab and SBRT, or a complete or major pathological response was observed. That was in total 53%. There was also some major pathological response. We know that in the immunotherapy only arm, but the odds ratio by integrating radiation was 16. So that was a tremendous effect. So there's now some strong hope that also in the neoadjuvant preoperative setting, combining radiation and immune checkpoint inhibition might be one step further. This is something which we all know. It is standard of care today, the Pacific trial in locally advanced non-small cell lung cancer, stage 3 locally advanced unresectable. They were randomized between durvalumab for 12 months versus standard of care and follow-up 2-by-1 randomization. Primary endpoint was progression-free survival and overall survival. And this is just very quickly the latest results, 4 years overall survival and progression-free survival. There's not only a significant, but a highly clinically relevant improvement in overall survival from 36 to almost 50% at 4 years, and progression-free survival improved from 20% to 35%. And this was an effect which was both on the local and systemic level. So we improved by this combination, systemic and local tumor control. I would like to go back here to our preclinical studies. What would be, based on preclinical experiments, the best way to combine radiation immune checkpoint inhibition, and how was it practiced in the PACIFIC trial? Well, it was in preclinical studies, we should use double checkpoint inhibition, was single in the PACIFIC trial. Small volume radiation, well, this was large volume stage 3. So there was some lymph nodes being irradiated here, even if they were not electively kind of targeted or delineated. This is shown here. Timing, preclinical tells us it should be done concurrently, but it was sequential. Small number of fractions, high dose per fraction in the preclinical setting, conventional fractionation in PACIFIC, and also the single fraction doses. So that should give us some kind of a motivation, I would call it, to even more explore the beneficial effects of combining radiation immune checkpoint inhibition. Either it works in any way, in any combination, that could be one strategy or one explanation. Another could be that the transfer of preclinical results to the clinics, we know it's difficult. And another kind of explanation could be, well, it works in this setting of PACIFIC, but there's much more room for improvement if we would apply these principles also in stage 3 disease. The next stage, oligometastatic, which has been mentioned briefly by Professor Suresh Senan. Progression-free survival in oligometastatic disease trials. You know the trials by Punis Yenga, by David Palmer, and by Danny Gomez. And this is the progression-free survival in the experimental arm, where the best systemic therapy was combined with ablative radiation or surgical approaches. It was all significant, which can be seen here, but simultaneously, the results are certainly not as good as we would like them to be. The majority of our patients still develops systemic disease progression because patients are indeed not oligometastatic. They have occult polymetastatic or occult metastatic disease, and that needs to be targeted by more effective systemic therapy. And that might also be a beneficial area to again integrate radiation and immunotherapy. This long table here shows you all the trials which have been conducted in non-small cell lung cancer oligometastatic disease, single arm phase 2 trials, randomized phase 2 trials. And you can see here the results. And there's only one trial which integrated on a systematic basis immune checkpoint inhibition. And you might have the impression that this also achieves very promising progression-free survival and also overall survival. This was the rationale for the ETOP chest trial, which we are conducting in the ETOP network. And the trial is kind of an all-in strategy. So from the very beginning, we combine immunotherapy in the form of durvalumab, chemotherapy, carbopaclitaxel, and SBRT to all oligometastatic sites. Then we do restaging and do definitive treatment of the primary tumor. That can be surgery or radiation. So that is a maximum to strategy to take the potential advantage of an immune-enhancing effect of both chemotherapy and SBRT added to immunotherapy. The last slides will cover the field of metastatic stage 4 disease. So not oligometastatic, but truly widespread stage 4. Is there a role for immunotherapy? Of course, it's a standard of care for the majority of patients, but might there also be a role for radiation? 2 trials have been published and reported so far where they investigated this question. Stage 4 non-small cell lung cancer, IO naive, and then they were treated with pembrolizumab, and the randomization was to SBRT, to one or limited metastasis, or just single pembrolizumab treatment. The pooled analysis has been recently reported in the Lancet Respiratory, and the effect was quite striking in terms of overall survival and progression-free survival. There was a significant, with a hazard ratio of 0.6 improvement by adding SBRT to immunotherapy if only one single metastasis or few metastases were being treated. That is promising. I would not say that this is clinical practice yet, for sure not, but this is something which needs further investigation in the form of clinical trials and translational research. With that, I would like to summarize my talk. The interaction between immunotherapy and radiation, it is there, but they are complex, and that is something we can modulate as radiation oncologists, and that is something we need to learn. Combination of radiotherapy and immunotherapy, we have good preclinical and also clinical rational evidence that this results in a benefit for our patients. Sometimes it's only promising, as I've shown you, for stage 4, or even practice changing at this point of time for stage 3 based on the Pacific regimen. The discrepancy between some preclinical work and the strongest clinical evidence we have, the Pacific trial, that indicates that there's still quite some potential for improvement, giving us a motivation to continue this field of research. And I would like to thank you and now open again the discussion. So are there any questions submitted in the chat? And maybe Nicolas, you would also join our discussion and we would kind of finish that symposium in a more interactive way. Oh. So Suresh, may I ask you a first question? Let's assume we have a situation patient having a widespread stage 4 disease, and he was treated with chemo IO and the patient responded well. So he's now in maintenance immunotherapy. And after quite some time, let's say 12 months, the patient develops an isolated progressive disease in the lung. We call it oligoprogression. First question would be, would you consider this a patient for adding SBRT to that oligoprogressive lesion? That would be question 1. And the second question would be, how would you deal with this immunotherapy? Would you just integrate radiation in between, or would you ask your medical oncologist to stop the immunotherapy to safely integrate, or maybe to integrate radiation? How would you practice and approach that?
Yeah, so we certainly would. I hope you can hear me.
Yeah, perfectly.
We certainly would consider it, but we are very cautious because of the literature coming out showing that these patients have an increased risk of pneumonitis, which can be quite troublesome if they have, if they get radiation under immunotherapy, particularly if they had lung radiation previously, or if they have had other serious adverse immune-related events. So I would do it, keeping in mind I have to use the best technique I can. I might use a very small fields onboard imaging, MR-Linac, to treat those with ablative doses. And because of the studies like the Pembro RT, and I wouldn't go to the highest doses like we do in the BD, more than 100, I would go to, say, a 24 gray or single fraction. The other part of your question was, would I wait for an interval? Well, the half-life of many of these agents is about 16 to 25 days, so it's irrelevant. I'm just bang on with it. But I do warn people because many of the tumor boards are just used to good news from stereotactic radiotherapy. They cannot believe that we can cause unexpected pneumonitis in patients who've had immune-related adverse events before. So it does surprise some people.
Nicolas, question to you, quick answering. Would we treat the patient? Would we kind of interrupt our treatment?
Well, current practice in Zurich is that we are not interrupting the treatment. But with regards to targeted or IO, we are rather cautious with anti-angiogenic treatments. Otherwise, we are not interrupting. But sometimes I find it difficult what is interrupting. So with a drug that you're using on your daily basis as a patient, like target therapies, interrupting is, I would say, pretty well defined. With other treatments that you give in more in a cyclic fashion, what is simultaneous. So if you give IO the day before your SBRT, or you give it 2 weeks before, if you consider the biological half-life, is it then sequential? Is it simultaneous with regards to toxicity?
There's a very similar question also in the chat asking, how do you integrate immune therapy, targeted therapy into stereotactic radiation? I'm looking at the time, it's 6:03. So if we would have 3 hours time, maybe we could address that question. But just a quick answer, we have done a systematic review a couple of years ago, published by first author Stephanie Kruse, addressing this question, how to optimally integrate. And we are currently planning a follow-up study, systematic review, and also combining with a consensus in this field to address the question of optimal integration. Then there's the last question, maybe also to you, Suresh. What is the optimal total treatment time to deliver 3, 5, and 8 fractions? So is it daily, or is it every other day, which we need to should deliver radiation?
There's no convincing evidence suggesting that every other day is worse or better than daily. Having said that, many people have not delivered doses of 18 gray and higher on a daily basis. There were some theoretical concerns, but I see no problems with giving 5 fraction schemes daily. 3 fractions I'll probably do every other day.
Matthias, maybe I would like to ask a last question I just spotted in the chat, which is quite interesting, and we will not get an exhaustive answer. But Suresh, what would be your recommendation for considering SBRT in a previously irradiated field?
If the organs at risk are not an issue, I would just repeat a radical dose. We had this feeling in the years when we were perpetuating this risk-adapted caring doctor concept. If it relapsed, we use a gentler scheme. But now, you know, if a surgeon cannot take it out, I would give it this, repeat the same three fraction, maximum 5 fraction scheme.
Okay, with that, I would like to end the discussion. Again, would like to thank you very, very much, Suresh, for joining our symposium. And as mentioned, this is the last mini symposium we are having in this series, 5x5. So it's also time to thank some people who have put a tremendous effort on making this reality. At first, I would like to thank our external speakers here. We had excellent speakers, keynote speakers from abroad presenting latest research, which has been published from them as first authors. Many thanks for them dedicating their time and joining our symposium. Also, colleagues from our department who have contributed, many thanks for preparing, many thanks for contributing. And finally, of course, there's a lots of work being done in the background. Michael and Brigitte, many thanks for supporting us, and also Livia. It was a fantastic experience. It worked perfectly. So we would like to thank and give you a big applause before I would like to officially close this symposium. I would also like to thank every one of you for joining, for spending your time with us, for the discussions we had. Stay healthy, take care, and I hope to meet and see every one of you at some, not virtual, but an on-site meeting, hopefully at Estra in Madrid. Stay safe and enjoy the European Championship.